Welcome to The Scope with Dr. K. I'm Dr. Kaczynski. We're going to open the show today, as we always do, by stating that the goal of this show is to present you with a broad scope of value-based care issues, mainly involving the field of gastroenterology, but also outside of GI as well. We're moving back to the patient side today with a rare opportunity to interview Tim Lash, president of West Health, a nonprofit foundation dedicated to building value-based care solutions for seniors. Let me explain, as this is a truly unique organization. Funded solely by the successful entrepreneurs and philanthropists Gary and Mary West, the nonprofit Gary and West Foundation is an outcomes-based foundation dedicated to lowering the cost of healthcare in order to enable seniors to successfully age in place with access to high-quality, affordable healthcare. Since 2006, this foundation has awarded over 700 grants, totaling more than $280 million to nonprofit organizations and other institutions that share this successful aging mission. Tim Lash is well-positioned as their president. He has been an entrepreneurial leader and chief executive in healthcare and philanthropy with extensive success shaping and executing disruptive delivery models, collaborative stakeholder groups, policy change, growth platforms, as well as successful acquisitions and equity investments. Welcome to the show, Tim.
Larry, great to be here. How are you?
I am great. Looking forward to these holidays like everybody else is. I typically start all of my podcasts by allowing the guests to tell the listeners about themselves. Tell us about your career. How did you become who you are?
Sure, Larry. So, I think like many of us, I spent my career in healthcare, just about 25 years now. And so have had ample opportunities to learn some things, make some mistakes, and hopefully not the same ones multiple times. But my career started in management consulting, focused on healthcare, doing strategy assessments and product opportunity assessments for medical device and pharmaceutical companies. After that, I went back to graduate school, get formal training in finance, and jumped to the medical device sector, working for Johnson & Johnson, where I had a number of increasingly leadership roles focused on mergers and acquisitions in the cardiovascular space, minimally invasive surgery, and then ultimately as an executive as part of the M&A team for one of their device sectors, which was about a $13 billion group. Learned a lot while I was there, but I think one of the key learnings, and J&J is a great company, but Madonna has disrupted herself many times over the decades. It's really hard for large multinational companies to do the same. And, I have a passion for healthcare, but I have a passion also for rethinking and reimagining how value is exchanged in the system and how we can deploy what are limited resources to help patients in the most effective way possible. And so I was at a crossroads and started looking for opportunities that would allow me to do just that. And I found myself moving from the East Coast to the West Coast to join West Health, which, as you said, is a nonprofit organization that leverages outcome-based grant funding, applied medical research, and policy research to rethink and reimagine public policy for healthcare, the delivery of healthcare, and ultimately the payment for healthcare to the benefit of our nation's seniors.
Your statement certainly emphasizes the passion you bring to your role there at West Health. You have three braided entities that work together: your foundation, your institute, and your policy center. Tell us about these.
That's great. So, at the highest level, I think what's really important to understand is that we were founded by Gary and Mary West. So West is a direction, on a compass, but it also is a family based here in San Diego, visionary philanthropists that solely fund our braided entities, the Gary and Mary West Foundation, the West Health Institute, and the West Health Policy Center. I'll tell you about each. But the fact that we are solely funded gives us incredible independence. We certainly have perspective around how we think healthcare delivery and healthcare policy needs to be advanced. But we're not beholden to outside funders or their agenda. And I think, that independence really is quite liberating, right? And can be leveraged by our team of experts as we advance the work that we do. So I'll start with the mothership. the Gary and Mary West Foundation, which, as you said, Larry, has deployed over 700 outcome-based grants through its inception to broadly advance something that we call successful aging. And so when we think about healthcare, we don't just think about the medical side of things. We think holistically about an individual, where they want to be, which is in the community, how they interface with the medical side of healthcare, right? And then, how they interface with other social supports and services, right? So that they can be, as healthy, as long as possible, but that they also have their dignity, right? And quality of life. And at its core, the foundation looks to deploy its resources to advance the successful aging of seniors. And we're all aging every single day. If we stop aging, there's generally a problem, that needs to be addressed. And so in aligning the delivery of care and outcomes for seniors, we're making, a very large impact on a needy population, but the benefit accrues really to all of us, even those that might not have reached the age of 65. The way that we achieve that impact is really quite unique. Most foundations across the country deploy a typical grant-based model where they find organizations that might be mission aligned or that they feel are doing good work, and they provide them with monetary resources as well as some expertise in some instances. The Gary and Mary West Foundation takes a different approach, and I'd like to describe it as a very highly leveraged approach. So the resources from the foundation primarily flow through two entities: the West Health Institute, which is an applied medical research organization, as well as the West Health Policy Center, which is based in Washington, D.C. And I call it a leveraged model because we take the vision of the foundation trustees and their expertise, we take the resources of the foundation, and then we flow them through an entity where those dollars are combined with decades of experience of RNs and physicians and system engineers and people with background in data science and backgrounds in telemedicine. And so we're not just deploying dollars in furtherance for reimagining, healthcare through outside organizations. We're taking those dollars and we're making them smart dollars. And we do the same thing as the dollars flow through the policy center. And that model has, I think, really allowed us to not only differentiate ourselves, versus, others that might be actively investing, to improve healthcare in the U.S., but it allows us to have the highest impact for every dollar that we deploy. We have done a lot of work around geriatric emergency medicine. The emergency department is the last exit, so to say, on the highway before we reach the toll, right? Which would be an admission. And we've successfully collaborated with the American College of Emergency Physicians to stand up a national accreditation program at 3 levels, like trauma, level 1, level 2, level 3, that has revolutionized how emergency departments across the country think about the care of older adults. Big problem, right? You require, a comprehensive approach. We've also done a lot of work around the high cost of prescription drugs, and on the policy side, we're very engaged in the work around Medicare directly negotiating the price of prescriptions for the benefit of the Medicare enrollees across this country, providing technical support as well as research at a public policy level, as well as patient research to ensure that policymakers really understand the true pain points, that Americans are realizing when they're at the pharmacy, paying, often exuberant prices for their prescription drugs, and that perspective was then translated into smart policy that could really make a difference. They're just two examples, but I think, Larry, you would agree these, they're illustrative of big problems that require a broad and coordinated approach that we're able to achieve because we leverage our dollars in addition to the expertise and perspective of a very talented team.
My first thought is define senior. So you mentioned the number 65. The patients you're focusing on, though, I would imagine are much older than that these days. Our definition of senior has to be advanced in age more than it has been in the past.
Yeah, Larry, I think that's, I think at the highest level, that is true, that the advances in, medical science, as well as, work that's been done over the decades around longevity, right, have by and large allowed people to stay, in some cases, healthier. But when we think about aging, I think it's important not to, think about a hard age cutoff. If you're an individual that has food insecurity, that you might not have been, so lucky to, sort of preserved your health, well past your 50s, and you're struggling in need of care that's perhaps more congruent with your health needs, even if you're in your 50s, and perhaps more care coordination that, per se, a senior center can provide. It's important not to be asking people for their licenses, right? To say, well, are you 65? 65 is, important as we think about, Medicare and sort of, other benefits, that might be available. But I think it's important to meet people, sort of, where they are, right? Both from a health perspective, regardless of their age, and think about, solutions in that context. Now, that being said, as we think about bending the cost curve, in America, for healthcare, it is true, right, that, as people age past their 60s and into their 70s and into their 80s, that we see a disproportionate amount of spend. And as we think about, value-based care solutions, it is really important to go after, those areas where perhaps you have the most bang for your buck, both in terms of the human impact as well as the dollar impact. And I think one program that I'd like to highlight, something called PACE, Larry, the Program for All-Inclusive Care for the Elderly, which, if for those of you that aren't familiar, this is a program that leverages both Medicaid and Medicare dollars, so state dollars and federal dollars, to keep seniors that would otherwise be in an institutional setting, so receiving custodial care, at home. It does that in a fully capitated risk-based model. So PACE programs throughout the country, they take funding on a monthly basis per patient, per member, from the state and from the federal government. And they have a great amount of latitude and longitude, right, in terms of how those dollars are deployed to support a patient on their medical side, as well as, just their needs in terms of activities of daily living in their home, to keep them out of a custodial setting. And the Gary Mary West Foundation 4 years ago stood up the Gary Mary West PACE program in North County, San Diego. And the vision here was, one, to make a meaningful impact for seniors in San Diego. We now serve over 350 very high risk, high need participants, but also to have a living laboratory, I would say, an enriched environment, right, where we can study what works and what doesn't work in a value-based setting for this high-need population. And we're now, in partnerships with programs across the country, as well as the National PACE Association, to leverage those learnings that were developed caring for this high-need population to inform other programs on how they can make real-time decisions, right, that can avoid hospitalizations and leverage things like telehealth to move the data and not the individual. And I would say those learnings are not just accruing to PACE programs, but as we think about bending the cost curve in this country, we have to think about how value is exchanged in a different way. And I said in my career, that's been a defining objective. And I think looking at aligning incentives and capitated models, right, are very fruitful areas that we can explore and expand as a country, right, to ensure that we're getting the very best outcomes at the appropriate cost for all of us, not just for seniors.
What type of interactions do you actually have on the provider side? Are you directly contracting with primary care groups, specialty groups? Give us an idea of how you run the nuts and bolts there.
Sure. So one of the hats that I wear is I am CEO of the Gary Mary West program, PACE program. We have a tremendous leadership team there that manage things on a day-to-day basis. But we essentially operate a full primary care practice that is staffed by physicians as well as advanced practice, sort of nurses and physician assistants. We operate a day center as well as a rehab clinic for physical rehab, occupational therapy, speech. We also employ mental health professionals to provide, for the mental health needs of the participants. that represents the core of the program, which really allows us to look at the whole delivery model, right? And the 360 degrees of the medical needs of an individual. There's an interdisciplinary team, Larry, that's responsible for all of that. But obviously the core primary care needs, as well as, PT, OT, et cetera, they don't meet all of the needs of someone that might otherwise be in custodial care. And therefore, we leverage, extensive networks of specialists, right, to provide for that care. But even there, we're rethinking and reimagining, how care is coordinated and provided, right? Does a patient need to see, a neurologist every time an internist has a question about the patient? Or can we leverage e-consults, right, for a more, effective, timely, and cost-effective approach? And the answer we have found is overwhelmingly yes.
The most impressive thing I'm hearing here is your ability to actually implement change. On the federal government level, glaciers move faster. But I'm impressed with the fact that you're actually leveraging the dollars and making them actually result in measurable change in the patients that are receiving the benefit from those dollars. That's very, very impressive.
The approach that we take is very deliberate in that not only is it important, I think, to be able to sort of, demonstrate that you are tangibly moving the needle at the level of the patient, right? At the individual level, that's critical because that's where the learnings happen. The operationalization of, any new delivery model or any approach, right? The rubber meets the road, on the patient outcome. And so by focusing there in some elements of our work, it grounds everything where it should be grounded, which is the patient better off? Is their family better off, right? Are we achieving better health at lower costs and doing it in a way that we can measure? But we don't stop there. That experience, I think, confers a tremendous amount of credibility when you start engaging at a state level or a federal level around policy or broader, system level projects to transform how healthcare is delivered, because you bring with you the perspective of the patient, the actual lived experience that you can point to and talk about, but you also bring with you the credibility of the learnings from the School of Hard Knocks, falling in the potholes, so to say, and putting your initials in them and then looking out for them moving forward. And I think there's a lot of wonky policy, shops in Washington within the Beltway, but we try to couple the expertise, of policy research with that lived experience, those learnings, that human perspective, to ensure that as we're advancing, whether it's a health system project, right, around the geriatric emergency department, or a federal policy on how we think about, paying for insulin, that we're bringing the applied human experience with us and the perspective of how things will actually be operationalized and, what are the intended consequences and what could be some of the unintended consequences. And it's really that approach that goes everywhere from, 10 foot, right, above the ground to the 25,000 or 50,000 foot approach of federal policy that I think, differentiates this organization.
If you're just tuning in, you're listening to The Scope with Dr. K. Our guest today is Tim West, president of West Health. Tim, I think we all have a very good understanding now of how the foundation, the institute, and the policy center interact with each other. You live by 9 principles for effective grant making. So I'd love you to weave your 9 principles into describing for us everything we need to know about this pharma initiative.
Sure. So Larry, I can list them very quickly for those that are joining, and then I think it's best to illustrate them in how they actually get deployed right in projects. And I think the hopefully the theme that has come across in the discussion so far, right, is we're looking to move the needle, right, and we're looking to move the needle in a time frame that we can all witness, not 10 years from now, 20 years from now. There are some critical needs for patients that need to be addressed in terms of, their access in the system, equity, the affordability. And the good news is there's a lot, while there's a lot that goes right in healthcare in America, there's some low-hanging fruit, right, that we can get at to bend. And so we really do think from the very beginning of, ensuring that our work is grounded in some things that will ensure that we're deploying our resources where they can be maximally impactful. So these principles that you mentioned come from learnings of the leadership team through, the work that we do here and the work that we've done on the for-profit, nonprofit, various settings. And so some of them are addressing a mission-critical need. And we've talked about successful aging, benefiting seniors. That's what we do. And it's important to ensure that everything that we do is grounded in that mission and that we're not, veering from that, right? Gary and Mary are visionaries. They've identified an area that philanthropy is well positioned to make an impact on. And that's the core of everything. From there, we really start thinking about, as I said, number 2, do we have a lasting impact? Number 3, can we achieve those results very quickly, right? Number 4, are we fostering cross-sector collaboration? One of the low-hanging fruits in healthcare is breaking the silos. We historically have a very siloed approach to managing really anything in medicine, right? And so the independence that we have allows us to think about cross-sector. We can't do things on our own. So number 5, establishing long partnerships that can be leveraged, not just for individual projects, but to develop themes and momentum over time. Number 6, leveraging institutional insights and furthering our learnings. Our team is our greatest asset. And as I said, the foundation deploys smart dollars. We don't just grant them out. We take the dollars and they flow through the West Health Institute. They flow through the West Health Policy Center, really leveraging the institutional insights of the tremendous leadership team and the project teams that we have. Number 7, demonstrating an opportunity for sustainable growth. One of the things that is really challenging, I think, in the foundation/philanthropy world is sometimes projects will never be successful but for philanthropic funding. We don't do them. So if something can't have an ROI that can't hunt on its own, absent the philanthropy over time, it doesn't mean that it's not a good project for someone else. It's just not something that we take on. And so that 7th principle is really key. And then the final 2, number 8, is a commitment to transparency. As a nonprofit, we share freely everything that we do. We share freely, our perspective on what we're trying to achieve. Our research, we freely give away. We want people to benefit from our learnings. We're not trying to accrue intellectual capital that's trying to be monetized. We're trying to accrue intellectual capital that's reshaping, reimagining, and disrupting healthcare. And that brings me to the final principle, which is number 9, that we're rethinking and disrupting the status quo through innovation. And I think here, the innovation term really needs a little bit of explanation. When many think of innovation in science, they think of new drugs and biologics and new medical devices. We think more about the innovation on the delivery side, right? Mm-hmm. Taking the resources that we have today and perhaps redistributing them or tweaking them in some ways that can have very meaningful impact on outcomes. And that approach really then contributes to all of the principles that I've talked about, right? In terms of our requirements of timeline and sustainability, et cetera, where we're not subject to these abject failure, right, of discovery. We're focused on the innovations and redistributing the things that lie in front of us. I think one of the best examples, right, of how this all comes together is a few years back, our foundation partnered with 2 other foundations, Arnold Ventures, as well as the Peterson Center for Healthcare, and 7 health systems to stand up a generic pharmaceutical company, which was called Civica RX. That model was looking to solve, initially a real problem that existed for inpatient drugs, in that we have these shortages that often come up for inpatient injectables that are generic. And the reason for those shortages, one, that sometimes there's not multiple sources of supply, and so something happens to one manufacturer, and if you only have one, you end up with a shortage, which can have tremendous impacts on patients, but they can also have tremendous financial consequences. There was a shortage a few years back of norepinephrine, which is used for shock. And when you look at the financial impact, billions of dollars associated with that shortage. When there are shortages, there can be predatory pricing. And so there's market failures that exist. And so the idea was to bring together, some initial seed funding from foundations and some seed funding from health systems to stand up an independent organization that wasn't beholden to the historical sort of market forces, right, of the injectable generic drug base. And Civica was formed. It now serves, I'd say, north of 50% of the hospital beds in this country through its membership, has north of 100 products, and really has significantly sort of disrupted the inpatient injectable space and made a tremendous impact on the shortages that occur across the U.S. But they didn't stop there, right? And so when I said you need a relentless dissatisfaction of the status quo, you need to disrupt the status quo. And so the entity of Civica, with the assistance of our team at the Institute as well as the health systems, said there are bigger problems that we need to tackle, perhaps that will benefit patients. And Civica announced several years ago that they would be pursuing an insulin program, a biosimilar insulin program, which continues to progress. And, hopefully we'll be filing for approval in 2025 for 3 insulin products that will be marketed somewhere around $35. That's not $35 copay. That's $35 total cost to the system, which is certainly something that will benefit patients, but will also benefit the overall healthcare spending in the U.S. And I think that example really illustrates how just over a few years we can demonstrate some of these principles, achieving a real impact, doing that quickly, doing it in a way that doesn't require additional philanthropy to sustain itself. Civica will be returning some of the dollars to the foundations so that they can be redeployed for other public good.
I'm gonna end it on what you just spoke about, because that just is a perfect example of how philanthropic funding can be utilized to impact real change and then establish a sustainable solution that goes forward and then feeds back into the philanthropic world. Thank you very much for being on the show today, Tim, and have a great set of holidays and keep doing what you're doing. You really are impacting change.
Thank you, Larry. It was great to be here. It takes a village, and these are important issues that we tackle. Literally, lives depend on it.
Well, thanks to Tim and thanks to the audience for tuning in. You can access our podcast on most all of the podcast platforms like Apple, Google, Spotify, others. Learn more about the show on the programs page on healthcarenowradio.com. Lend your voice to the conversation on X at HC Now Radio, and follow us on Twitter at SonarMD. We're bringing patients, providers, and payers together to reimagine care. Until next time, I'm Dr. K. Stay well.